Eagle Labs. And so we use this place quite a lot. And I think the first time we came, there was probably about 3 of us. And last time we came, there's probably about 12. So from our point of view, in Channel 3, it's really important that we base ourselves out of places like this, and we base ourselves locally to where we operate. And so a little bit about Channel 3. We are a bunch of people that, by and large, are ex-health and social care. We've all been around the block quite a bit. Some are a bit younger than me. I'm one of the oldies. But the thing that unites us is that we all have this belief that people have the right to live the best lives possible and have the best experience of the health and social care system when they need help. And that part of the answer to that is doing digital better. So when you get an event like the Leeds Digital Festival, where everybody's coming together and they've all got their own different takes on that issue, you get a really interesting array of sessions to go along to. So we're pleased that we've had this one. We're pleased that you're able to come. And there are other sessions as well, which the guys are going to talk about in a minute, because I know that you're all over this, and you're veterans of the Leeds Digital Festival in a way that I'm not. So we've managed to get an esteemed panel of people together for us, and rather than me introduce them, I'm going to start with Monica. What's your come from?
Thank you very much, Scilla. I'm Monica Jones. I'm the Chief Data Officer for the University of Leeds, and I'm also an Associate Director of Health Data Research UK, which is the National Institute for Health Data Science. So I've worked for the NHS for many years before I worked for the university, and lovely to be here.
Fantastic, thank you. Nicola?
Thank you, Scilla. So my name is Nicola Stevens. I'm the Director for Innovation and Strategy for the Leeds Health Partnership Office of the West Yorkshire ICB Board, as we're now called, and also for Leeds City Council. I've got 19 years experience in the NHS. I've worked with public health, various NHS teams and at IG, and I'm currently leading on the Shared Care Record Programme for Leeds as well.
Fantastic, thank you. And Steve?
Thank you. Good evening, everybody. Stephen Blackburn. I work for the Leeds Integrated Digital Service, which oversees digital service and support for the council and for what was the CCG. And I'm the innovation manager overseeing that area. So I get involved in smart cities stuff, data, innovation, all that kind of good stuff.
That's fantastic, thank you. So before we get into it, let's just talk a little bit about Leeds Digital Festival then. So this is the first time that we've been part of anything here, but you guys are veterans of this, and in fact you've got other things going over the next week or two. So do you want to say a bit about what you're doing and maybe shamelessly plug your other events?
Why not? Yes, so the university is involved in a number of events. I'm doing a presentation on Monday at 10:30, which is an entirely online session about our new data strategy and the data service that we're setting up. So feel free to register and join in on that. And I think Nicola's got quite a few other ones to talk about, haven't you?
Yeah, so we're within Leeds, as Stephen mentioned, we've got the integrated digital service that sits across the council services and across health. And we've got a scheme called the 100% Digital, about digital inclusion for everyone. So we've got about 9 events across the festival. So they're available online, and there's some really interesting topics and sessions being done. And then tomorrow we're hosting a hackathon at Nexus, which is looking, well, I think it's sold out now, isn't it? So, but that's going to be a really interesting day. And then we've got a day on the 4th of October that is just outside of the festival due to the unfortunate Queen's funeral and the events that happened. And that's a supplier day where we're looking at robotic automation and the art of the possible to look at how you can revolutionise the NHS and council services.
That's fantastic.
Yeah, and the hackathon one for me tomorrow is the big one that I've been involved in helping to organise. So we're really looking forward to that. If anybody does want to go, we are oversubscribed at the moment, but if anybody does want to come to that, we might be able to sneak you in. So just let me know about that. And also, I'm on a panel session on Thursday afternoon, I think it is, next week, which is being organised by Forum Central. So it's third sector, and really to discuss our digital strategy and the work that we've done there.
There is one other event which is next Thursday, which is about the digital skills for the city and the importance of education and digital skills, and educating children as they come through, and the importance of that for all people of Leeds. Tom Reardon from the council is actually going to be part of that event, and Eve Roodhouse, who's one of the economic chief officers for Leeds, and that's a session all morning next Thursday at Hunslet, and we'll be talking about how that can be linked to businesses across Leeds, some of the SMEs, the innovation arc, and then looking at apprenticeship schemes that come out of that for 16 to 18-year-olds and then 18-year-olds and graduates as well.
That's lovely, thank you. I mean, that leads us on to really one of the themes of the session, which is about thinking about the structural challenges that the health and social care system faces across Leeds, the population health challenges, and what's really driving that, because the problem might manifest itself in health, but actually it's an education problem or a housing problem or a justice problem or an employment problem. And Monica, you've been involved in public health and population health analytics for quite some time. Just talk us through a little bit about how you think about the challenges that a population like Leeds might face and how you go about trying to size it and understand what the drivers of challenge might be.
Yeah, absolutely. So a programme that I worked on until recently was the Yorkshire and Humber Care Record. So that was one of the sort of the fondly named LICRAs, the Wave 1 LICRAs, the local healthcare record exemplars. So in 2018, we had some funding from NHS Digital to essentially, not NHS Digital, NHS England, they're all the same now, aren't they? AEIOU, sorry. And in order to try and join up 74 organisations across Yorkshire and Humber for a population of 5.5 million people, which is no mean feat.
Yeah.
And the approach we took was quite innovative, and there are colleagues here today who worked with us on that, so it's great to see those familiar faces. And what we decided that we've got, very much a sort of an eclectic mix of electronic sort of patient records and systems across Yorkshire and Humber. So actually the best thing to do was to try and join them up using open standards.
Yeah.
So we applied those and had a number of use cases where we could actually incrementally build up and create a longitudinal record on the fly, which actually at the time NHS England didn't really believe that we could do, and so we were on the naughty step for a while, and then we sort of proved that we did it. Went, that was rather clever. So actually, joking apart, we had also the opportunity to then generate those data in order to be able to use them for population health management. And you're absolutely right. We need to understand what the characteristics of our population is, and that's not just from the people who are sort of going into hospital. Those are it's from primary care record, it's from community, it's from mental health, and across the board. And I'd done a similar kind of exercise when I was CIO at Rotherham Foundation Trust, and we built the Rotherham Health Record, and it was a similar kind of approach that we then sort of took across Yorkshire and Humber. Because if you don't know what, who your population is and what their sort of needs are, you haven't got a chance really of doing anything in order to be able to sort of bridge those gaps and tackle some of those health inequalities and actually sort of improve outcomes. So there is now a central population health management system. We've working with the ICSs and over the last sort of few years, sort of building that up and sort of taking it forward. And it's something that personally I'm very proud of. I think there is still some way to go. And Nicola and I were just talking about it earlier about, sort of bringing in some future ways of working around the Leeds Care Record and how we sort of integrate that into the sort of the regional sort of records. But, it's about being able to use sort of the concept of trusted data environments, and actually analysts and those people who are entitled to sort of see the data when it's pseudonymized or anonymized, being able to access those in secure, compliant places in order to be able to run their own sort of analytics and then be able to look at sort of new models of care.
Yeah.
Yeah.
I mean, there's a lot there to unpack,
There
isn't
is.
there? There's a from the engineering level to making data available at point of care to improve decision making in a clinical setting. But coming right up to the top, I'm guessing that Nicola and Stephen, the challenge you've been wrestling with is how you create an integrated care system and how you throw your arms around a place and figure out what it's like and how you can improve health and social care.
Yeah, I mean,
is that top of mind for you?
Well, if you take it back to the basics and you look at Leeds, Leeds has two populations, so to speak, because it has the ONS registered population of 812,000, but then it has the actual registered population of the GP registered population, which is currently about 872,000, which is obviously significantly different, and they're the people who are registered with GP practices and residents in Leeds. So obviously you're already set up with a difference in terms of your population figures. And if you look at Leeds and some of the targets that you measured on nationally, Leeds is average, and we just classed as average.
Yeah.
But then when you start to drill down into the populations in Leeds and you look at some of the wards or the neighbourhoods, our areas of deprivation in Leeds are actually bigger, and what is classed as our deprivation population is actually bigger than some of the cities nationally in other areas. So we have a high deprived population in Leeds, and that's where the significant differences start to come in, and there's like a 9-year gap in life expectancy in Leeds between some of the areas of high life expectancy and the lowest life expectancy. And this is where population health becomes really important and about commissioning for the health of the population and the care of those. So having access to a shared care record and the ability to share that information as people move through the system is really, really important. And we're about to publish a digital strategy for Leeds that we've just done. And we've done it on the 4-life stage approach, which is in the public health model, which is like living well, working well, ageing well, and starting well, because it all starts with a child and how they're born, and then obviously the education that they have, the wider determinants that they grow up in, and then obviously the journey that obviously they go through in life. But as somebody goes to their GP practice, they then assume that if they go through community care, they go through social work, they go to a hospital, that everyone sees all their information in one place.
Yes.
And that isn't the reality of what actually happens. It's not all joined up at the moment, and it doesn't matter where you are. And that's what we're trying to achieve with an integrated system in Leeds at the moment.
Yes, it's a huge challenge. It's a huge engineering challenge, and it's a massive transformation challenge.
It is.
Because it touches everybody's role, doesn't it? Everybody's
does.
job needs to be redesigned. But the point you make about the life expectancy across different areas of Leeds, I think that's true for lots of our cities in England, but nowhere is it more true than Leeds. You can literally walk the length of Leeds, and you can knock a year off your life depending on which
From
route,
north to south,
which
yeah.
route
Yeah.
you take as you do that. And that must make life really difficult when you're designing services. But the integrated care systems, the idea is that you integrate health and social care. You can create a joined up service response to the challenge. So Monica mentioned the ICS. So can you just catch us up on where you're at in Leeds in terms of integrating care services? You know, how mature is the ICS? What's happening with it?
The West Yorkshire one, I'd say, is quite advanced. The West Yorkshire ICB, it has won awards. Rob Webster's the chief exec for West Yorkshire. The Leeds office of the West Yorkshire ICB, which still doesn't roll off the tongue quite so easily, is up and running. It has a board. It works under the partnership. You know, we've got a partnership executive with all the chief execs in Leeds. They do work within an integrated way. Health and social care in Leeds has worked well for a lot of years. We've got a very good relationship between health and the Leeds City Council and social care and the Community Hospital Trust. I think things have changed over the last few years. So when we initially did the shared care record, we didn't have things like primary care networks, we didn't have neighbourhood network teams, we didn't have MDT teams in the communities. So all of that's changed since 2014, since we did the shared care record. And that's the changing landscape that we now have to work towards within a shared care record. So it's the ask of the frontline people that they're working in different ways and delivering services within the communities. So that's what's changed, and that's based on national policy, the way that things are working within communities, and we need to respond to that to be able to work to people's needs.
Yes, yeah. And so Monica, from a research perspective, Do you see the outputs of the analysis that you're doing in the research community really landing in ICS land, or do you think it's a challenge? Or
I think we've made a good start, and certainly the working relationship between the University of Leeds and Leeds Teaching Hospital as one of the largest trusts in the country. At one stage, it was the largest. You know, we've got a good working relationship, and there have been some, you know, specific sort of projects and programs that we've been working on, not least through HDI UK, and recently we've worked together around looking at the effect of COVID, not unsurprisingly, on various disease areas, in particular sort of cancer. So the Digital Innovation Hub for Cancer, DataCan, was a collaboration both of the university and LTHT and other organisations across the country. And so we were in a position to actually then work with NHS Digital on using the National Trusted Research Environment. Yeah. So, you know, it's that's been a huge sort of innovation and an opportunity. And I've always said sort of from the beginning that we would be sort of critical friends and collaborators. And we're in the same city, so let's actually capitalise on that sort of, you know, feeling and bond of sort of being together. You know, it's not been without its challenges, and particularly with the migration of the, you know, the National Disease Registration Service from PHE to NHSD, you know, that's brought its own sort of challenges. But actually, since the Goldacre report, you know, the actual understanding of trusted research environments and secure data environments, and also the public sort of acceptance of that, and the technology, frankly, catching up with our requirements, has made a massive difference, almost like an order of magnitude improved. So we've sort of been working on that and really sort of assessing the sort of the impact, and moving forward for the next sort of 5 years. We're just in the process of sort of setting up a whole sort of set of programs. One, picking up on that work on the complex data for big data for complex diseases, which we're bringing in not just cancer data, but cardiovascular data, and actually sort of looking at how we can really sort of take our research sort of analysis, but on routinely collected sort of data, and actually take it to that level of quality. And I think it's absolutely inherent that we work very closely with the ICBs and work with our sort of colleagues both at place and regionally to really sort of understand that, and you know, so I'm really quite excited about the opportunities.
I'm really struck by that, and to Nicola's point about the quality of the relationships between the different agencies and the different partners in care across Leeds is actually really strong, isn't it? The links between academia and health and social care are really strong. And I guess, Stephen, when you think about, tell us a bit about your work on smart cities, and maybe if you could sort of talk about how being in Leeds is really helpful to developing your vision of what a smart city might look like.
Yeah, I mean, we've done a fair amount of work on sort of innovation over the last few years on our smart cities kind of type work. I mean, one of the bigger projects that we've done more recently was a £1.25 million government-funded project looking at how we utilise IoT devices in council houses. So, and we made the link there between the home and the person's health. So how can technology help us better manage the home, which means that people are living in a better environment, and therefore their health and well-being is likely to be improved. So that was about collecting temperature, humidity data, so that we can understand in real time the environmental makeup of that property, and we can be more proactive in terms of ensuring that that property is in the best condition it can possibly be, and therefore can impact on people's health positively as well. So we've done an awful lot of work in trialling that kind of technology out over the last couple of years, and in fact to support a lot of that IoT type work, we've built a new LoRaWAN network, long-range wide area network. That's open, free, accessible, so anybody can go out and buy some sensors and utilise the network that we've built. That enables us to go out and buy this type of Internet of Things technology to collect data in real time, whether that be in the house, whether that be something to do with adult social care, managing people's health. This is not personal data, I have to say, just to be clear on that one. but it enables us in a way that we've never been able to do before to collect data in real time, to be able to deliver real-time services and target those services to individuals as well, and really understand what's going on in people's homes, for example.
Yes.
And we want to promote Leeds as an innovative city. And we, as has been mentioned, this isn't just about Leeds City Council or any particular organisation doing it for ourselves. This is about working collaboratively across the city and encouraging that collaboration, that innovation across partners.
Yes.
And we want to promote, and that's the reason, to some degree why we're sat here today.
Yeah,
we want to
absolutely.
really promote the work that we're doing, and we want to encourage other people to get involved in that as well.
Absolutely, and that sort of fundamental enabler, things like making wireless network available across the city is a key enabler of some of the transformation that you're trying to drive. I think thinking about public health analytics and that discipline that we've been in for a bit of a while, we know that housing is a challenge, and we know that education is a challenge, and we know that in some areas, and it's easier to say than do, if people took more control of their own health and well-being, and you kind of, to use a horrible expression, activated the patient, so we all took a bit more responsibility for our own health and well-being, then that is one potential route to alleviating some of the stresses on the care system. But it's not easy to do, is it? So the Internet of Things idea that you spoke about, how's that landing really with people? Are people embracing that idea of living in smart homes that help them be more well for longer, living at home with less contact with care services, or are people finding it challenging?
I would say we're starting out on those conversations at the moment. We take a person-centred approach to what we do, so it's important that people are involved in those conversations right from the outset, because if we're wanting to introduce new technology and deliver our services in a different way, it's important that people are involved in those conversations, because they'll ultimately be the recipient of those services and more likely to adopt them when they do get introduced.
Yeah.
But certainly in terms of the housing projects that I mentioned, people were involved in those conversations right from the very beginning. We can't just turn up with a new gadget or a box and say, don't worry about it.
Yeah.
So we're having those detailed conversations. Also conversations, of course, as you would expect, with our information governance colleagues to make sure that we're doing everything in the right way. Just because technology enables us to do something doesn't necessarily mean we should do it.
Yes.
So absolutely, data and digital ethics and how we do it and how we go about it are at the core of what we do. And in fact, we're having just started conversations now, like Nikki mentioned that our new digital strategy is just about to be published. That will really provide us with the steer of the new innovative and innovation work that we work on and prioritise going forward. And we're starting to have those conversations with colleagues, for example, in adult social care, and look at how this type of technology that helps people to manage their own care better themselves in their own homes. How can we engage with their customers, and how can we engage with suppliers and look at the innovative solutions that are out there and start those conversations with those customers.
I think it links really closely though to the 100% digital inclusion, because it's about being inclusive for everyone, and not everyone has access to digital. So one of the schemes that we do in Leeds through the 100% digital is allowing people to borrow digital technology, because there are financial challenges. We see it every day on the news, and we have to be mindful that not everyone has all of the latest technology. So there are schemes available through the council, through the community hubs, that allows people access. But then you also have to bear in mind that not everybody wants to access services through digital, and it is a personal choice. So it is the personal choice of the person, and making services available to those who want to access them in the way that they want to access them. So that links back to the 100% digital work that's going on in the city. And then we're working with the British Libraries. There's a scheme so that there's a new digital hub opened in the library in Leeds, so that people can go in, talk about digital, have training if they don't know how to use digital devices. Even from just turning it on, how does it work, accessing information, because, to some it is quite daunting to suddenly work in that way. And then how they can access devices in these community settings, in the community hubs. And then for the wider determinants, it is thinking about the financial challenges, because yes, it's okay to say people should take control of their health, but then that has other implications as well. So what is their housing situation? You know, what is their personal circumstances, and it all links in together. So it is about all the agencies linking together, which is what we are doing in Leeds in the neighbourhood network teams and the hubs.
Yeah, I think we can be, you know, going back to your point about sort of taking control of sort of, you know, healthcare and sort of, you know, population health management, you know, we can be smarter about sort of risk stratification. So classically, we've identified sort of, you know, people by their chances, you know, it's all been around avoiding hospital admissions. Yes. It's literally that one sort of, you know, bilateral sort of flow, and, you know, and the classic model that sort of primary care have sort of used around you know, identifying you're at risk top 2, 5, 10% has essentially been the model we've used for many, many years. And yet actually, you know, as Nicola has said, there are so many more other sort of factors that actually we can sort of bring to play. So going back to the sort of, you know, the using the data for population health management, actually having a proper sort of population segmentation sort of model where we can actually sort of understand what of the you know, the cohorts and the characteristics are, then being able to sort of look at the where the gaps are, particularly around sort of, you know, deprivation and around sort of, you know, high burden sort of groups of people who really can't get out of that sort of, you know, that kind of loop, and say, right, okay, what are the genuine risks? What let's try and use some predictive sort of analytics around that, and actually work, you know, in the communities in order with the primary care networks, with, you know, sort of colleagues sort of across both, you know, sort of primary care and community, but also, you know, across the other sectors, to really try and sort of tackle those kind of things. And there's been a number of sort of, you know, programs of work just across Leeds and across sort of West Yorkshire and also across sort of Yorkshire and Humber, where we've really tried to focus in on that and use the really sort of informative sort of data and challenge ourselves not to just do it the old way, because we've always done it that way. And yeah, we had a pandemic that just sort of came along and knocked us all a bit off track. But actually, you know, some of the digital sort of rollout and sort of adoption has been actually one of the benefits that's come out of the pandemic. You know, we're all sort of working in hybrid ways and sort of remotely and stuff that we probably wouldn't have, well, we did dream of it actually 2 or 3 years ago, you know, and those of us who have worked in the NHS and you know, in digital for a number of years have been trying to persuade people, and then suddenly overnight it happened. It was like, wow, you know, goodness me, let's actually try and embrace this, and let's not actually, you know, the elastic band is stretched. Let's not let it go and go back to old ways of working. Let's actually keep that sort of nice tension on it, and actually let's actually capitalise on those improvements that have been the good things that have come out of the pandemic, and actually let's use the data in order to help and support us.
It's such a topical issue, because I don't know if you heard Teresa Coffey on Radio 4 this morning talking about essentially in the pandemic, if you close the front door on primary care services in the way that people have conventionally received them, you have a pandemic, you come out of it. They were talking about a 2-week aspiration for a GP appointment. The shadow health secretary was on talking about, well, we did it in 2 days, and you get into this kind of bun fight. But actually, the challenge is more in the area you're talking about. How do you reimagine those services? Learning from the things that worked before the pandemic, during, and the things that will work after are quite a challenge. And I imagine that's the sort of thing that keeps you awake, Nicola, at night, trying to figure out how the digital component of that's going to work.
We did really well. I mean, I actually, if some people may have seen my post on LinkedIn, my responsibility and my team's was to roll out all of the IT for the GP practices in Leeds. And we had to do it within a week, 2 weeks, to get them all online, because you couldn't close the front door to primary care. And actually, we did it, and the primary care embraced it. And actually, the patients of Leeds embraced it because they needed to maintain those services. Obviously, there was always still a face-to-face service for those who needed it. I won't say it was currently, completely shut down. People could still see a primary care professional. But actually, some really good things have come out of it. We've got a system, I won't say which, because other clinical systems are available. But what I will say is one of the systems that we adopted through that, which has become quite famous nationally, it's actually loved by our primary care.
Yeah.
Because actually, you can have a telephone conversation, they send you a text message, you can send pictures, they can actually link to you live, you send it back, and they send questionnaires by it, and it's instant. So like for me, I suffer from asthma. My asthma review, instead of having to go to the practice, sit in a waiting room, go in for 5 minutes, have my review and take half an hour out of my day, I actually can do that by text now in 5 minutes.
Yeah.
So it's had some massive benefits, has the pandemic, because we were looking at doing that, but it was rolled out, not just in Leeds, in other areas as well, but it was rolled out really, really quickly.
It's changed the conversation, hasn't it?
Yeah.
But I guess just linking together sort of three things that are coming out from me from listening to you talk. I mean, Monica, you're exactly right. That sort of risk stratification, patient segmentation into cohorts, and then streaming through the most appropriate route is a kind of macro way of looking at patient flows through a care system, and thinking about, Stephen, about the opportunities in social care and in people's homes to make that an option for people other than turning up at the front door of a hospital. And Nicola, you've got the challenge of scaling all that sort of thing, haven't you? So, and also to your point about it's not right for everybody, so how do you personalize it? So I guess you've got people going, scale this, and then you've got other people saying, personalize this, and you're sat in the middle trying to figure out what gives.
Well, one size doesn't fit all. I think,
Yeah.
it's a bit like going into a clothes shop, isn't it? There isn't one size in a clothes shop. So, it's what suits the person, and what's right for them. And so there will be different varieties that are available, I think is probably the best way to put it.
Yeah.
So, there is online consultation tools now. It's a national mandate from the government that online consultation and video consultation is available within primary care. There's national procurements out at the moment. So practices will continue to do that. Hospitals are now doing that and offering online consultation as well as face-to-face consultation. And I think that's one of the shifts that is in primary care, but it enables them to see more patients. The teledermatology programme that was rolled out in Leeds and has been piloted now in other areas, that saved an awful lot of time. So if someone potentially had skin cancer, an image could be sent immediately to a consultant within LTHT. They could assess it straight away rather than having a 2-week, 3-week wait for an appointment, and they could see straight away whether it was at risk and whether they needed an appointment. So there are real benefits from some of the digital solutions, and it stopped the patient worrying about that for 2 to 3 weeks to get an appointment, because they could see from the images that there wasn't a risk and they didn't need an appointment. So I think it's looking at what's right for the individual services, what's right for the person, and balancing that at the end of the day.
And the phrase that we use in the digital strategy is digital first, but not digital only.
Yes.
And I think that's important. This isn't about just shifting everything online.
Yes.
Online and apps and the new technology can support the service delivery that exists already.
Yes.
And it might take some of that away from face-to-face, which means there's more time for those people that do want face-to-face consultations, because other people want to access services in a digital way. But it's about having all of those solutions and then, tailoring that to the individual.
Yeah, as appropriate, and as the individual wants to consume those services and as they want to be provided. How is this impacting on your staff? So if you think about something like the digitisation of cancer services that you spoke about earlier on, are you seeing that change in the way that staff operate? Are you seeing it have an impact on them? Are they embracing it? What are the challenges? How's this hitting your workforce?
I think there's different in different workforces. I mean, for the cancer service, I would say that's more secondary care than primary care. For the primary care element, for the teledermatology, I think it was very, very positive, because for them, it was positive results for their patients, because they could get, practically instant results in response from a consultant rather than having to wait, and that anxiety of having to wait for those results. So that was a positive for them. And obviously they get to see more patients if they're doing the online consultations, the telephone consultations. So within Leeds, there's a lot of telephone triage appointments. They can do that, send images, so you don't often, in some cases, have to go for a face-to-face. Obviously, it's decided if you need a face-to-face. So they can get through more. So there are benefits to the patients in that way. And one of the things that really struck me when we've done some of the engagement sessions was I went to the BSL community to do an engagement session about apps and online consultation. And I did a presentation, and it was there's a lot of people from the deaf community there, and they said that the actual digitisation of the app and online consultation was fantastic for them because they'd struggled for years making telephone appointments, and they had to wait till somebody was available to actually make the appointment for them because they couldn't, the voice activation, they couldn't do it, or the person at the end of the phone struggled, and actually the NHS app and the online consultation that came on board for the GP practices enabled them to do it at a time that was convenient for them and suited them, rather than having to wait for when an interpreter was available or somebody was in their house if they were living on their own and actually could do it for them. And when you think about it from that perspective, it's really meaningful, and the impact that it has on someone's daily life.
Yeah, thank you. Can you give us a bit of a spoiler alert on your digital strategy? So what's in it? Give us the scoop.
Well, it's the format has been, I think, well received because it's very simplistic in its format. So it's got the basic foundations, and it has, it's been written from a place perspective, which is unusual. So it's on behalf of all of the partners in Leeds, not from one organisation. And what we've set out, it's very ambitious. So these are the outcomes that we're going to achieve, but what it means for the staff and for the citizens of Leeds and from the people of Leeds. And actually, Stephen's just been to present the strategy in Paris, which was actually well received, wasn't it?
Well received, even in Paris.
Yeah. And he's been asked to go back.
We want to take. No, fortunately, they understood English. I did say
we're
that.
going to do Stephen's globe trotting in a minute, right?
Yeah.
And for anybody in the room, spoiler alert, right? Stephen's got to be your best friend because he's going to Barcelona, and he'll tell you about that in a minute.
Yeah. I'll let Stephen share about Barcelona.
Tell us about Paris then. So
Yeah.
what did they make of it in Paris? What was it that particularly appealed about the work that's been done?
Well, it was very similar. I don't know if anybody here has been to the Smart Cities Expo in Barcelona. So it's a big deal. Lots of technology, cities presenting what they're doing there, and up to the pandemic, the Leeds City region had a stand, had a stall at the Barcelona Expo. And we were the only UK city there to have that sort of physical presence, which is great. And in fact, in 2019, when we last went, there were 60-odd, we had a 60-odd delegation, which included people from the university, from the council, SMEs, people like that. So really, really good promoting the city. And they're trying to do something similar in Paris. It's only the second year that they've done it. So they're looking to really build on do something similar to Barcelona and build on what they did last year, and it's a bigger event this year. And it was really good to see technology, lots of technology out there. Again, we were we were invited to go and speak about our strategy, about our innovation. Our innovation strategy is linking to the digital strategy as well. And really, I suppose what I spoke about was that whilst we've done innovation work in the past, perhaps sometimes it's not been as strategic as it might ought to be.
Yeah.
Proof of concepts here and pilots and one thing and another. And the idea with the digital strategy is that we are clearly articulating, clearly outlining what the priorities are for the whole city and how digital technology can improve the outcomes and lives of the citizens of Leeds. And it will be our innovation work that is neatly aligned to that particular strategy so that we're focusing our efforts in the right area. And so I spoke about that in Paris. We've been asked to go to Barcelona in November again, so we can give them an update there. It'll be the first time we've gone back since the pandemic. And yeah, we were the only UK place there to present. We were invited by the Department of International Trade. And who knows? Fingers crossed. They said they might invite us back to the British Embassy in Paris to talk again. So who knows?
There you go. There you go.
Who knows? Well, if we're doing top trumping.
Go on, Monica. You're off to Hong Kong, or something like that.
No, I did go to Jamaica at Easter. I've actually been working with colleagues, helping the Jamaican government actually.
It won't endear you to people. Say you've been somewhere else, but it's raining outside.
Digital health strategy, but actually I've drawn upon a lot of our experiences in Yorkshire and Humber, and the approach of, the Jamaicans can't actually sort of afford to go out and buy some swanky American sort of system off the shelf. So actually they are building their systems using OpenEHR, using SNOMED, using open standards from scratch. And so I've been working with colleagues through my own sort of work, but also through a collaborative, a global e-health collaborative that was a not-for-profit organisation that we set up a few years ago, working with colleagues in Australia and in the US, really to help them. But the model that they're taking is not going to look that dissimilar to some of the successes that we've had in Leeds, and that I think is joking apart, it shows that actually if you design something properly and you do it in a strategic way and you do actually use sort of open standards, and my personal strapline is you can't have quality without standards, and I know some people might find them pretty dull, but actually it's the bedrock, it's the way of getting our systems to work and talk together, it's a way of getting it to interoperate, and actually as a global community, we've put a lot of effort into it. So why would we try and reinvent the wheel? But actually, let's make it relevant to our own sort of place. I'm going to
come back to shared care record in a minute and talk about standards and talk about the Yorkshire and Humber care record. But I just wanted to pick up on something, Stephen, you were talking about, which is about, I love that point you're making about lots of POC, proof of concept projects, lots of pilots, and often we are accused in our dominion of having POC-itis and not scaling things out, the great ideas. And it's great to see you talking about how the Leeds digital strategy is going to be influenced by the need to deliver an outcome. So from your point of view, Monica, do you, from the university and from a public health and from research background, how do you get involved in defining and setting what those outcomes look like in a strategy for a city like Leeds?
Well, actually, we're just about to publish the university's data strategy. I'm not doing a spoiler alert. You'll have to dial in on Monday at 10:30. But you know what? There are component parts of that are absolutely identical to what we've been talking about today. And Nicola and I were talking about it earlier. We've known and worked with each other for years. It's about being part of the city and tackling things in a citywide way. And from the Vice Chancellor, Simone downwards, our 10-year strategy for the university is very ambitious. It is actually about global impact. It is about us actually, within Leeds sort of making a difference. So it's about getting our own house in order to start off with. And, there hasn't been a chief data officer at the university prior to this year and sort of my appointment. And, I felt it was really important for us to be able to describe sort of what we're doing, and from both a university, both education, research, and sort of, from a corporate perspective, is turning data from being a burden into an asset.
Yes.
Because we do, we've all been involved with central returns and turning the handle and feeding the beast. But actually, there's a whole load of data that is generated. And actually, rather than just essentially archiving it once we've used it for one thing, it is about data reuse. It is about sort of sharing those data. And a lot of the work that we've done through Health Data Research UK has, frankly, over the last 5 years, has been about highlighting that. So there is a publicly available portal, metadata portal. We've defined a metadata standard. We actually created a data utility framework. It started looking at quality, but actually we felt we wanted to extend that and into sort of, what makes it useful for researchers, for analysts, for data scientists. So we published that in the BMJ, and that's been applied to all of the data sets that are on the gateway, the innovation gateway. And it's about taking that to the next level, because if you don't know what you've got, you don't know what you can do with it. So I think it's really important, you know, to to have that sort of described in order to then be able to say, right, what do we want to, what are our outcomes, what is our ambition, and how are we going to, you know, achieve that, and where are the gaps, and let's actually try and plug those gaps.
Yes. So thinking about your space a little bit more, the developments in Internet of Things and wearables and other devices are generating a whole new stream of data that's useful, not been used before necessarily, and a whole set of challenges as you think about not just embedding the device in clinical workflow, but also how you use the data and the probity of the data and the standards you apply. Is that something that you're thinking quite a lot about as you develop things like virtual wards locally and kit out homes? Is that, do you have a whole area of people who are looking at that as an issue?
Yeah, we've just recruited a new Chief Data Officer for Leeds under the Integrated Digital Service, and he'll be working jointly with Monica to do a data strategy for Leeds that'll include all the data ethics. That's on the back of the national strategy that was published. So obviously there are really strict guidelines on that, but the wearables and some of the new devices are having really good results. So it's like VR headsets have been used with dementia patients, and they've had really good results and success because it allows them to do things that they're not able to do, but they can actually do things that they used to do, but in the VR world, if that makes sense.
Yeah.
And it gives them that sense of calm that they may not have, you know, depending on if they're having an episode. And it allows that their carer also to have maybe a length of time to be able to get something done. They've been used in some of the care homes, and we've been trialing them. So there's all sorts of different technologies within the council. You know, there's drones being used to look at roof repairs rather than sending somebody up on the roof.
Yes.
They can actually analyse the damage on roofs. The roofs across Leeds then actually do a report using that data, which is a lot quicker. And then you get the information practically instantly. There's road sensor devices that are being used to look at, you know, where roads need to be gritted in the winter so that the gritters are sent out in the right place. So, you know, there's all sorts of things.
I think there's a couple of areas really. So, I mean, for example, the gritting of the roads. Yeah. So we can collect data using IoT devices specifically for that road gritting service. But also we will capture that data centrally as well. And we're creating a new Office of Data Analytics, which will bring data together from a variety of sources. And we'll have key personnel who will be able to analyse that data and maybe reuse that data, analyse it for a completely different purpose, not for anything to do with gritting the roads.
Yes.
We've done a lot of work in the past on open data, for example, and we manage the Data Mill North website, and that's a regional site where we can publish that data. And again, all this real-time data via APIs, we would want to make that available and accessible for other people to reuse that data as well. That enables people out there to provide even more insight into that data that could provide value back to ourselves.
It's targeting services, isn't it? So the weather, the gritter, slips and trips, A&E, orthopedics, you know, those data points, when you start to link them together, you get to a point where you're thinking about almost personalizing services, you know, looking at where you're targeting interventions. And there's a kind of perceived wisdom that personalizing health and care services by nature expensive. But it's my hypothesis is actually not, because you're eliminating waste, you're really targeting resources in the right place. And it sounds like the work that you're doing, it's really interesting listening to you. All three of you got different perspectives, and yet clearly work together in quite a close and integrated way. It's really fascinating. So the shared care record, can I bring you back to that?
Yeah, sure.
So catch us up on where we're at with shared care records across Leeds.
So in Leeds, we formed the Leeds Care Record in 2014, which was designed as a programme, obviously, for a shared care record. And that had a specific purpose and a programme of work. And at the time, it was very advanced. There was a lot of publicity about it. Obviously, we're now in 2022, and we've outlived the life of that programme. So we've formed a new board, a new programme of work for the Shared Care Record programme. And that's based on really the shape of the organisations that now exist in the world that we live in. So this is, you know, the social care, the care homes, the neighbourhood teams, the community hubs, the third sector that are delivering healthcare. You know, there's lots of different people providing services now that are outside the traditional models of health and social care that need access to a record and are not on a traditional EPR system. So that is the focus of the new shared care record, and how we integrate that information to a person-centred approach. And that will link in, moving on, to a personal health record, which we hope to use the NHS app as the front door. And I think everybody knows what the NHS app is because it was the COVID passport. And if you wanted to go anywhere, you needed the NHS app. So that is the aim of where we're going. And obviously that data will be surfaced in at some point in the Yorkshire Humber Care record. So in a nutshell, that's where we are.
Fascinating area. I mean, there's a sort of there's a philosophical difference, isn't there, between records being owned by the NHS for the NHS and created by the clinicians and curated by them, versus they're being owned by the citizen, and then the citizen syndicates access to their record whenever people might need it. And it's a really interesting point where we're going to have to figure that out, because everywhere's implementing personal healthcare records in some shape or form, and whether that's just through harvesting IoT data, or whether it's through HealthKit or my Fitbit, or whether it's just through me taking a photograph of my doctor's notes and keeping it on my phone. You know, it's a really, really interesting area that everyone
like bedtime reading, therefore. It's a very interesting point that Nicola raises, and that I think we've also got to be careful that we don't leap forward in some sectors and actually leave some of the others much further behind. So in particular, care homes. So some of the work we've been doing as part of HDIK North through the Better Care Partnership has actually been about digitising care homes. So we've taken a model that they started in Newcastle and Durham, and then actually sort of extended that almost sort of down the East Coast, down to sort of Sheffield as well. And it's really about, it's an app, but it's a system that actually care home staff can actually use for sort of decision support and triaging and making those difficult decisions that in the past they didn't feel necessarily empowered to be able to do. Even if somebody was on a particular sort of care plan or a sort of end of life sort of plan, the tendency would still be to pick up the phone and call an ambulance. So what we've done with that is actually really work with staff and colleagues and carers, sort of both in the care homes and with families, to actually help them to just have a little bit more confidence about making the right decisions and connecting with, maybe the GPs, or actually just having the confidence to say, Mrs. Smith is okay. But actually that connects up to the hospital or to the GP. And it's been really well received. And we got some additional funding, not unsurprisingly, during COVID, because of the big sort of issues around sort of care homes. So I think it's really important that we actually don't leave people behind, and that we make sure that we're investing in all of the sectors as part of that sort of work. So once again, I feel very proud of what we've done sort of on that side of things, and some sort of medication reviews. We've looked at antibiotic prescribing, and particularly in frail elderly, sort of where you're on multiple medicines. And the interaction sort of between those, and then feeding the data back to GPs and so that they can actually see what their profiles are around antibiotic prescribing, and also some work that Andy Clegg, who's a consultant geriatrician in Bradford but a professor at the university, has done on the frailty sort of risk scores around anticholinergic medicine, which are prescribed to a lot of frail elderly, around some of the sort of the side effects that happen that people don't really, aren't necessarily sort of aware of. And that, that's across the board. There's clinicians as well, because of that combination of sort of prescribing. So we've digitized that, and we've been running a program using the Bradford care record, but also then sort of, looking at that, how we would extend it across sort of Leeds and sort of West Yorkshire as well. So some really
you
good sort of
you
work
find
there.
those, don't you, with shared care record initiatives, that there are certain scenarios where you get a lot of adoption because it requires multi-agency collaboration to look after the patient. So in other shared care record areas, end-of-life care has been transformed really by the ability to have the data following the patient so that services can be redesigned, and bringing hospices into the loop has been really successful. Are there particular examples where the shared care record has really driven value for patients in the Leeds area? I think you spoke about a frailty programme that you're involved in.
There's the frailty programme, but also there's a new national mandate now that's come out for digitising social care. So that came out in April this year, and it's to be delivered by March 24. And that is for care homes. It's for CQC registered providers of social care. And one of the national policies came out in June this year as well about digitising health and social care. So we've been successful in getting quite a lot of funding for Leeds with adult social care and with the West Yorkshire ICB. And that is about digitising all of the services that are still on paper records, which obviously there are quite a lot. So the CQC providers can apply, for grants through us to actually start to work, and we will do a wraparound service with them to actually start to digitise some of those services. And there's been 7 suppliers on the framework nationally to start to digitise those areas and get them onto, first of all, onto an EPR system. Then obviously they need the infrastructure putting in, but then it's getting the NHS mail accounts, getting the IG training in. So there's like a whole series of steps that you need to do to onboard them, besides then digitising the record. And then once they've gone through all of that, then they can go on to the shared care record itself. And then, they're using the things like the app and doing the work that we're doing with Monica. So there's a whole series of events. But obviously things like the Villa Care Ward programme in Leeds, the delayed discharges, all things like that help with the Leeds Care Record, and being able to access that information.
You're pretty good at generating case studies, and for those people that might be interested in what's happening in Leeds, you can find all those on Tinterweb.
There's case studies as another spoiler in the digital strategy.
Oh, there we go. So
One area.
One last question. I'll give somebody else a go after that. But sorry, I'm enjoying this. This is brilliant. So, thinking about, so Leeds clearly is full of the best looking, most intelligent, youngest, and most vibrant people in the world, and recruiting in Leeds is really difficult. So, how are you getting on finding people with the data science and analytics skills, the people with the digital scale out skills, the IoT gods? You guys have got a heck of a recruitment challenge. How's it going?
Please contact us if you want to digital or BI, because we have vacancies. Contact me, not Monica.
We try to share and not nick each other's, but there's inevitability
We've
about
agreed to share.
moving around the city. I'm doing a recruitment campaign at the moment for staff, but actually, what we're doing is really promoting sort of Leeds as a great place to live and work. I've also formed a collaboration with Women in Data, which is a national organisation, and we're doing an event on the 21st of November at the university, and really sort of bringing in sort of, examples, but also sort of not just looking at your sort of traditional sort of workforce. So, people who perhaps returning to work after a career break, or children, and we can work so much more flexibly now because we're working either remotely or in a hybrid kind of way, that actually what I want to do is reach out, and to women in particular, and get more women into data and into technology, because it is exciting. We've talked for an hour non-stop about how important it is. That doesn't mean that men can't apply. Please don't think I'm saying that, but it's. I think it is really important to actually be able to tell those stories, and also to say, actually, look, you really are genuinely going to make a difference, and the work that you do is going to improve lives, and actually come and work for us because we're great.
The stories are
the whole
incredible.
package. You might not get this exactly the same salary, but you add on the pension and the leave and all of those other things that come with it. The University of Leeds has more holidays than any academic institution in the whole of the UK.
I think the
Here we go. Nicola and Steve are going to make the fight now. Here we go.
the other thing it links
You go to
to,
Barcelona if you go with Stephen.
The other thing that I think it links to for Leeds is that we've got a really good inclusive growth strategy for Leeds, and we're working with a lot of the economic development, and that's through Eve Roofhouse with for Leeds. So it's got a good inclusive growth policy that's working with all of the businesses in Leeds, the SMEs in Leeds, and there's a lot of development, the innovation arc in Leeds. So I think there's a lot of opportunities for digital in Leeds as a whole, you know, outside of our own organisations and companies that are moving to Leeds. And as you know, Leeds is going for the Eurovision Song Contest, so we're bidding for that.
Excellent.
So I'm the biggest fan. So
Do you know, we're almost like Bucks Fizz, but not quite.
So fingers crossed, this time next year we might all be in fancy
How
dress.
Bucks Fizz look now, I think it's pretty close, actually.
Well, while you're making your mind up. So, anybody out in the floor? I've dominated the questions here. Go on, my friend. You were first up. Excellent.
Yeah, Scott Considine, really interested about data that you mentioned earlier on, Nicky. But first of all, thank you all very much for your insight. Really enjoyable and really sort of interesting. So with Leeds being like a 24/7 bit of an international city, obviously there's a lot of temporary / transient people come in and out, and unfortunately at times, speaking of the Eurovision Song Contest, people might have a share but too many, or just have an unfortunate incident where they will have to utilise the services. Is that sort of data captured? And in some ways, does that actually skew any data, or is it how is that data managed? If you use
Do you want to go
A&E,
it is captured because they're classed as an episode at the Leeds Teaching Hospital. So obviously it's coded through the SNOMED coding and through the coding at the hospital, and obviously it's then tariffed, so obviously that has to be paid for. And then it's worked out within the system, but obviously it isn't then back to a resident as a Leeds patient. But obviously it is captured as information within the system at that time. And then that information would be then sent back to where that person is actually a resident. So if they're an out of Leeds patient and they're in this country, then that information would flow back to where they're an actual resident. If they're not a resident within this country, then obviously it is more complex about where that data flows back to.
We do get some very interesting sort of analytics from big events. So if you think back to the Tour de France when it started in Leeds, and we essentially as a city mobilised, didn't we? We even took the bumps out of Clarendon Way for the ambulances to be rerouted. So actually our expectation was that there would be a whole load of sort of like, you know, extra sort of stress on the system. As it was, A&E attendances really dropped because people were out sort of, you know, watching other things and not in the city getting drunk on a Saturday night. And so actually being able to look at that data set and analyse it for a big event like that and understanding our population and the people coming in is really, really valuable. You know, and it was fascinating doing the analytics sort of on that. You know,
There's some amazing data in it.
Yeah.
I mean, we did a piece of work looking at flows of patients into A&E in the LGI, and looking at what the impact of a big event, like a Take That concert or when the footy's on or that kind of thing, and you just see different flows of patients. But thanks very much for your question. Brendo, the Agile people, they are very, very good. We work with them a lot, so I'd give them a plug. Hannah, you had a question.
Yeah, I guess we've touched on workforce a couple of times. I think a really important thing to consider is that often the workforce in health and care and other public services is a significant proportion of the community that you're then trying to use digital to help. Has anyone got any kind of thoughts on the opportunities of that existing workforce as being a kind of bridge between the community and the tools and the technology and the data?
Yeah, I mean, certainly from my experience, you know, particularly when we were building the Yorkshire Home Care Record, we definitely mobilised the workforce. So as well as actually sort of building the technology and our sort of central sort of data repository, we created a digital academy. So what I wanted to do, I was really determined that we would upskill the workforce sort of across Yorkshire. There's no point in creating a sort of a super whizzy sort of technology and people not being able to use it. So, classically sort of analysts working in hospital tend to do sort of the routine kind of, reporting, regulatory reporting, all of that kind of stuff. And I wanted to give them the opportunity to be able to upskill to do sort of advanced analytics and essentially sort of health data science. So we ran one academy face-to-face in the city before COVID, and then we've subsequently put a lot of that stuff into modular work and training, working with Health Education England, and actually then sort of we're extending that sort of reach to a much broader sort of workforce. So I think it's really important not to forget the people working sort of in the system, but also we sort of created multidisciplinary teams, across the CCGs, across the sort of council, across the both primary care and acute, to actually say, right, how can we do population health management sort of analytics at place, and let's do it together, and got them sort of working in their teams together as part of the sort of training, but then they could hit the ground running when they went back to their places, and working with some of the other sort of education sort of networks, working across with NIDIF and ICD and other sort of really good sort of continuous professional development, helping people to get more sort of digitally aware. So that's definitely something that's always close to my heart. Yeah.
From our perspective, so I suppose I should have mentioned I've also got a CIO role across West Yorkshire for the West Yorkshire ICB for digital skills, and that is for generic for all staff within the healthcare system and across Leeds City Council. So under Leeds City Council, we're actually creating a digital academy, which is a training for all staff, not just people within the digital. So it's staff across all services and directorates. And that will link with the 100% digital inclusion team to actually get people to a basic standard of digital skills. And that is the digital competency that everyone should be able to be at. So there's a team of trainers, and we've just recruited to the head of the Digital Academy within Leeds City Council for that. There's a digital skills strategy across West Yorkshire that will be published that we've done with the West Yorkshire Combined Authority, and that has 4 elements to it, which we can make available after this. And then there'll be a programme of work working across West Yorkshire with the authorities, with all of the trusts, about how that is promoted within each of the organisations and their training schemes, and obviously trainers, to get people up to different levels. And so that when things like 365, Teams goes out, that they're not just sort of dumped on people's desks and say, oh, right, you've gone live with that now and it's got a new ribbon, just deal with it. It's about how do people interact with the tools that they get when they get them. Because as an example, at the council, we've got 4,000 people who don't operate on a technical device. That's out of a staff of, a lot bigger, but it's when they get these devices, we have to onboard them to those devices and actually talk them through using these devices.
And we make specific reference to that in the digital strategy as well, that on the one hand, whilst we focusing on digital inclusion, getting people online for the first time who have those very basic digital skills, it's also important that we acknowledge the wider workforce, both within our own organisation and across the city, I might add as well, because technology moves on at a pace. We all need to keep up to date with our own digital skills as well. And in particular for us that are delivering public services, if we don't have the right skills, then how can we expect people who are accessing those services to be able to access them?
Exactly right, yeah.
So we're all doing build-a-thons next week and building power apps.
Yes, power apps.
Fantastic.
RPA are the
So
buzzword.
I think we've got time for one more question, if anybody's got another question. Yeah, please.
Hi, yeah, question about data and the digital side of that. So what, we talked a lot about population health and digital data, and there's an awful lot of qualitative data about people's view on services and people's view on their own health in Leeds, and that's in a similar place to where quantitative data was many years ago. It's in silos. So the university has chunks of qual data on patient experience, and the health service does. Every council service has feedback from its big pool of user. Is there any kind of plan to, or do you see that as a challenge in terms of trying to harness that and then focus it at maybe even at a PCN level?
Funny you should say that. There was a meeting today and it's called the Patient Centre Advisory Group for Leeds, which all the agencies are on, the third sector groups, and all the communities, and that's where they look at what are the views of the citizens or the person as they want to be referred to in Leeds, and the people, and that's where we collect, because it's the communities who know best, and where we collect that really rich qualitative data from, and then that is fed into the services, and how do we use that to actually make a difference, and what are the actual needs that we need to consider. And so there's now 11 population health and care boards for Leeds, and people will be represented on those boards, and that's where some of that information will be collated and then fed back.
Yeah, and I think it's really important, you know, that actually we have really good patient and public engagement. Certainly with the YHCR, we did 3 big sort of communication sort of exercises. One initially about, you know, how the population felt about us as using their data, and then we did a much more detailed one around population health management, and then actually sort of, you know, the sharing of data and the details of that. And it is about genuinely listening, capturing that qualitative data, being able to pick out the common threads, and whether you do that in a, you know, in a traditional sort of way, or whether you use some kind of sort of, you know, natural language sort of processing is obviously an option. But actually it's almost as simple as, you know, what sort of, you know, Nicola said, is about listening and genuinely listening, and actually being able to then play that back into the system, and not just playing lip service to it, to actually genuinely working with, you know, across all the population to do what's best.
That's fantastic. Well, thank you so much for being so generous with your time. Really appreciate it. And I thought that was a really good discussion. I hope people enjoyed it here and listening online. I think that, well, hello online. Hello.
I've just got the bright lights in my face.
We'll never stop waving.
Yeah, well, hello. Like the penguins of Madagascar. So I think that when we started conceiving this session, we talked about how you go from that macro scale understanding of the demands of a population and some of the challenges that people face. We spoke about how those challenges are different for pockets of Leeds. We spoke about how you use that information to redesign services. We spoke about how you can use technology to enable some of those services to be redesigned. We talked about using innovation in technology to provide different channels for patients to access care as they might need them. We talked a little bit about health and well-being and some of the determinants, wider social determinants of health. We talked about social care. We talked about partnerships between organisations sitting across Leeds, and we talked about how that was building those relationships and working together is really key. We talked about how you're rebooting your strategy essentially, and that's going to be coming out soon. And we talked about some of the great ways you're engaging with the digital community across Leeds. So I don't think we've done bad over the course of that.
Well remembered.
Yeah, always thinking. So I thought that was absolutely fantastic. So I'd like to say thank you again to Stephen and Nicola and Monica. We thought this was a good idea to try and do something on your way home. And so we've had a great conversation. There is a free bar. There is a load of food. And keeping with our Yorkshire theme, we have 2 recent graduates from Leeds College of Music who are going to play for us while we do our mingling. So I hope that's okay for everybody. Thank you so much for coming along on this wet night in Leeds, and I hope you've enjoyed the quality of conversation as much as I have. So can we just say thank you to our panel? Thank you. Thanks very much. Oh, I know it's a bit. It was high, that, wasn't it?
I'm going to fall off the
high.
stool. Oh, no. I have got numb though.
That's all right, isn't it? Was there?